for the warm invitation. I want to share you my technique about the treatment of choroidal detachment associated or not of retinal detachment. My work was presented in the prestigious Congress of Veil Vitrectomy in Colorado this year. And as you know, you have two types of choroidal detachment, one associated or not of retinal detachment. The first part of the choroidal detachment associated to the non-retinal detachment can be occur by after surgery, by surgery filtration, or ocular trauma or retinal photocoagulation, infection or inflammation. And of course, we have 8 patients with choroidal detachment not associated to the retinal detachment, treated by this technique. It's treated by EVT viscoelastic 1 day before, and the cause of this 8 patients, 4 cases after surgery, 1 after glaucoma filtration surgery, 2 after vitreoretinal surgery, and 1 after cataract surgery, and 1 case after EVT of anti-VEGF, and 3 cases of pan-uveitis. Of course, the primary replication of choroidal detachment was observed for all patients. A recurrence was observed in 2 cases requiring further injection even 3 months for each patient. Significant improvement in visual acuity and disappearance totally of pain of this patient. No serious complication was observed and no case of refractory ocular hypertension. This is the case of patient who have hypotonia, pain of 2 eyes, secondary to the choroidal detachment and hypotonia, and one day after after injection, complete disappearance of choroidal detachment, and the patient don't have pain again. The big part of choroidal detachment was associated to the retinal detachment, as you know, and it's a severe form of clinical of the retinal detachment. Why? Because it's associated of a number of pre, intra, and postoperative problem that may affect the visual prognostic and affect the surgery. The incidence is variable, and it's associated always with height myopia, and the literature was late and efficient before my discovery. A clinical aspect of choroidal detachment, as you know, in the fundus, hypotonia, anterior uveitis, choroidal detachment, and or retinal detachment associated, and of course the aspects is typically in the B scan. And if you operate this patient without treatment of choroidal detachment, you can have choroidal invasion. Of course, if you have extended choroidal detachment, and it's very important to search a place to put your infusion to avoid any extension of choroidal detachment. The physiopathology described before my discovery, it's poor and inefficient, and related to the hypotonia, intraocular inflammation, ciliary body, and of course the treatment was proposed is inefficient, like steroid, or for some time dangerous, like vitrectomy and puncture of choroidal detachment, which provoke hemorrhage, for example. And the paper which I published, it's in journal in French Journal of Ophthalmology in 2021, with and I describe this cycle vicious for this illness, for the disease, to be simple to understand what happened and what you can propose like a treatment. And to understand this disease, the primary movements of this disease, it's the hypotony. The hypotony for some patient associated with choroidal detachment, and choroidal detachment behave like indentation, like stellate buckle, and close the tear. When the tear was closed, of course, you have disappearance of choroidal detachment, of retinal detachment, and when retinal detachment disappear, we have you increase the pressure of the eye, and with the pressure increase, you have disappearance of choroidal detachment, and when choroidal detachment disappear, you have opening of the tear, and of course, again, retinal detachment, and again, hypotonia. For that reason, you can see the same patient in this same week with different aspects of the fundus. And here we can see with choroidal detachment associated with retinal detachment, or only with choroidal detachment, or only with retinal detachment. Of course, the technique is very simple. The first study, as I told, is about 8 patients, and now we have over 100 patients treated with this technique. And of course, it's the biggest data in the world treated with this technique. The etiology was in the half patient, height myopia, pseudophakic, and for some cases, giant-tear. The treatment is like AVT of anti-VEGF or steroid. But here you inject viscoelastic, like viscot alcon for the study. And you can inject 1 syringe or 2, independent of the pressure in the eye and depend on the size of eye, of course. Complete reserve of all choroidal detachment after 1 day or 2 days. And zero problem of hypertension. You can practice your vitrectomy 1 day after, and the primary replication was observed for all patients. Of course, 5% recurrent retinal detachment operated with success in this patient. And for me, in my experience and for my patient, this high level of recurrence is relative to the PVR associated to the patient which had choroidal detachment with retinal detachment. And the technique is very simple. It's just 4 millimeters from the lambus. You charge your syringe with a needle, 30 gauge, and you inject until you have a good pressure. And you can start, and you can again try to inject. And in the final, it's all. You can, it's minus 1 minute or 2 minutes, and you prepare the second day you can operate your patient. Here, a patient with choroidal detachment and small retinal detachment, you treated it 1 day before, 1 day after. You can have complete disappearance of choroidal detachment, and of course, 1 day of surgery, you can have a good result because you operate sample retinal detachment. Here, a mix of choroidal detachment and retinal detachment, inferior tear, and of course, 1 day after treatment, complete disappearance like magic. Complete disappearance and easier and simple. Complete disappearance of choroidal detachment and retinal detachment. And of course, you can understand the disappearance of choroidal detachment. But the retinal detachment, why disappear? Because of course, the viscoelastic here like a cork in the tear, and of course they treat transitorily the retinal detachment. And of course, you can operate the same patient 1 day after without any problem because you are in front retinal detachment. Like here, it's the same patient, and you can operate it for 10 minutes without any problem with silicone tamponade because it's inferior tear. This is the aspect of fundus 1 day after. Here, complicated case, retinal detachment, giant-tear, PVR, and two big pockets of choroidal detachment. 1 day after, you have just the retinal detachment and the PVR, and of course the surgery is a little complicated because with the PVR, and this is the final fundus aspect of fundus 1 day after. Here it's a huge choroidal detachment, even arrive at the posterior pole. 1 day after injection, complete disappearance of choroidal detachment with this sample technique. And after this, after surgery, of course, you have the final aspect, final beautiful aspect of fundus. In conclusion, I can say that the technique with the EVT viscoelastic is innovative, simple, safe, inexpensive, and reproducible technique to treat choroidal detachment associated or not with retinal detachment. This technique allows to avoid potential intra and post-operative difficulties, to simplify surgery, and to improve prognosis of this complicated type of retinal detachment. Thank you for my team, And you can save the date about my two congress. The first one in the beginning of May the next year of the retina, and the second one of the big congress of general ophthalmology practice one in the beginning of June. Thank you very much.
Thank you, Dr. Zidi, for this nice lecture. And any questions from the audience? Because I have a question. If there is no questions, yes, please. You can have this microphone.
It's a very nice innovation. Congrats for that. I have three questions mainly. So one thing, we are using a viscoelastic inside the vitreous cavity, and we are using a 30 gauge needle. Viscoelastic is slightly thicker compared to the anti-VEGF injection what we inject. And when you are doing a cataract surgery, we use a 23 gauge needle what we inject inside the antechamber. So with a 30 gauge needle, how much force is required to inject inside the vitreous? And the second thing is, there is a choroidal detachment inside the eye. Do you see, we don't know how much deep it is. So how are you sure that you are inside the vitreous cavity when you are injecting the viscoelastic? And the third thing is, how much volume, how will you decide, sir? How much volume of viscoelastic to inject inside the vitreous?
Okay, for the first question, if I remember the question, it's about
the needle part of it, the gauge of the needle.
Yeah, when you with the syringe of viscoelastic classical one, you can charge it with a needle, and of course it's little hard to inject it, but it's okay. And for this patient, that I recommend to have a complete dilatation to see the needle into the eye, like the video what I presented, to be sure that you are not in the pocket of the choroidal detachment. That's the first thing. And the second thing, you injected until the eye can be hard. And don't worry. Why? Because you have, in the same time, you have disappearance and drainage of the choroidal detachment serous one. But this choroidal detachment is serous, it's not hemorrhagic. And you can assist at disappearance immediately. And after this, you can check your eye. After 1 minute, you find it with the good pressure. And the third question is about? Yeah, it depends that I told. Depends of the eye. For my experience, I injected until half syringe to 2 syringe and half. It depends in the volume of the eye, and the repair is the pressure. When you have good pressure, you stop and you operate your patient one day after.
Thank you, Dr. Zidi. This was one of my questions. I mean, injection, as he said, is going to be hard at the beginning because the eye is hypotenuse. So once you have hypotony, it's very difficult sometimes to get inside. Second thing, it's where you inject, because sometimes the bully of the choroidal detachment, you might inject not in the vitreous, you might inject subretinal, and this is a big mistake if you do that, because you will ruin everything. So it needs like, what can I say, planning, where you are going to inject, how much you are going to inject. And as I said, you are not counting on how much, you are counting on feeling the pressure, seeing how much is the pressure, and then you continue injection and you stop. But this is a very good, safe, and I think it's very cheap idea to release the detachment, because once you get in and you have choroidal detachment, you might lose the whole eye. And this happens a lot of times. Once you go with choroidal and retinal detachment and you start the operation, sometimes the hypotony kill everything, and post-operatively we get a disaster after that. Exactly. So this is a very good and cheap and simple idea. Anybody can do it, but again, it needs a little bit of cleverness and it needs training. And then once you inject and you release the pressure, will be a very good idea to start your operation second day.
Yeah.
Thank you so much for this, and we appreciate this. And then we have a kind of appreciation from you, from the academy. You see, he left his breakfast to come and give you this trophy. I called him, but he said, I'm having breakfast. I said, Dr. Zidi, it's much better than the breakfast. There's something to appreciate your presence and your lecture. Thank you so much. And can we have a picture together? The three nice girls in the front, these are Moroccan girls, right? Yeah. Why don't you come with us? So you will remember your professor is getting, appreciated. Why don't you come with us? Please. Yeah. That would be a nice, instead of 3 men, there is a 3 women, okay? Or 3 ladies. Okay? Yes? Yeah, not decoration. No, don't say about them decoration, please. No? And even Ashraf, he's another decoration. Thank you so much. Thank you. Thank you. Thank you. Thank you. Thank you. Can I call my panelists, Dr. Gharabli, Dr. Hijjar, Dr. Prasan Rao, and Dr. who's محمد أحمد سلام المفروض جاي. Please. مش عارف أحمد هيجي ولا قال لي أنا هجيب قهوة واجي بس there is many chances. هجيب لك. دكتور زيدي معانا كمان. دكتور زيدي معانا. موبايل أنا. أنت فاتح لي البرزنتيشن. مش هتفتح البرزنتيشن ولا ايه؟ مش مفتوح. انا مفتوحه عندي بس مش باينه على الشاشه. Today the panel is about every raid data challenge. It's not a mysterious case. It's the usual and the daily practice. We see a lot of cases. But let me introduce my guests. The Dr. Brahim Al-Gharabri from UAE, Dr. Mohamed Naeem Nasr from UAE, Prasan Rao from also Emirates, and Sharat Hedga from India, and I'm expecting, and Dr. Zidi, of course, from Morocco, and I'm expecting Dr. Ahmed Salam to come in, but I'm all